welcome all of you to this very important session where none other than Dr. Nageshwar Reddy, who needs no introduction. He's the past president of WEO, that's enough, I believe. He's the, sort of Pied Piper of the world of endoscopy, right? So he shall be speaking, giving the chairman's address on endoscopy in 2021. So without wasting time, I invite Dr. Nageshwar Reddy to start his chairman's address. Dr. Nageshwar Reddy, please.
Thank you, SP. Thanks a lot for the introduction. We come to the penultimate session of this wonderful conference which Manoj, Avinash and the team has organized there. A very well organized conference, and at the last session I've been asked to talk on the new tools in endoscopy in 2021. So these are, it's a very wide range subject, but I have about 25 minutes, so I'll try and confine myself to areas of endoscopy which are new, which are making optimum outcomes better in patients with gastrointestinal diseases. So when you look at new tools, there can be new scopes and new accessories. Again, I'm going to only talk on those that are currently available in the market and what we're using on regular practice. I'm not going to talk on those which are in a stage where they're being developed and so on, because this has to be more practical. Now, let's come first to the new scopes. Among the new scopes, the most interesting addition is the new image-enhanced endoscopy by Olympus. It's called the EVS X1. Now, what has happened in this is normally in regular endoscopy, you have blue, green, and red light. They've added another light called the amber light. So this EVS X1 has got an amber light, a fifth LED, for better reproduction of the blood. And so you can see this when the blood is flowing through, the red light actually goes to the deep vessels. The amber light is also absorbed by the deep vessels. Can you see the slides? I can hear some talk. It's okay?
Yeah. Please go ahead.
So the amber light is absorbed, and the hemoglobin which absorbs the amber light has a separate spectrum from red light, and therefore the color of the blood becomes a little different. That makes bleeding vessel very easy to see. So you can see this deep vessels very well with this, and I'm going to show this very nicely. This is a patient in whom was achalasia. We first do white light, and you can see that in white light you can see the vessel. Then we go and do narrowband imaging. On narrowbanding, you see only superficial vessels, opposite, only superficial. And then we do this red dichromatic imaging. It's called the RDI mode. And RDI mode, you can see the deep mucosal and submucosal vessels. So the deep mucosal, submucosal vessels, which are not clear in the regular white light is seen here. And how does that help us? It makes entry into submucosal space easy. We can identify where the vessel is bleeding from, resulting in immediate hemostasis, lower mucosal injury, and lower stress. In fact, we just completed 30 cases study with this scope and found that even for a beginner, POEM becomes very easy, and I'll show you why. This is a report we presented in GI endoscopy, how the red dichromatic imaging can be used for POEM. And you can see the deep vessels here very nicely, submucosal vessels not seen normally. So then we know that we should avoid that an entry. So we do an injection, raise a bleb there away from the vessels, and then we can actually cut away from them. If you see in the white light, everything looks like vessel. But when you go to red dichromatic imaging, you see the superficial vessels are gone, only the deep vessel is seen. And then we'll make an incision. This is the deep vessel. Beside the deep vessel, we make an incision so that no bleeding occurs. So what we found that using this technique, even for a novice, learning POEM becomes very easy. The field is bloodless, and you can see how nicely we can avoid this deep vessel. This is a deep mucosal vessel, and even submucosal vessels can be made out. So our incision is made in this patient away from the vessel so that there's absolutely no blood, and that gives the confidence. The stress level for the endoscopist also comes down because you can see how this opened up very nicely. See this? So this is the second part is when you're doing submucosal dissection, when there's a bleed like this, again, you can avoid stress. You look at it, and when you change to the red dichromatic imaging, this is the regular light imaging, texture enhancement imaging. See what happens. When you switch to RDI, the bleeding becomes very soft, and you can see the central area where it's bleeding from very nicely. And this can be caught with a hemostatic forceps and very easily burnt. So this is the major advantage of red dichromatic. So now in our unit, we are slowly switching over to doing all our ESDs and poems using this new scope, which has got red dichromatic imaging. You can see this. This imaging is also incorporated into the baby scope, the mother and baby scope here. And you can see using the red dichromatic imaging, the superficial vessels are gone, whereas with NBI, superficial vessels become very prominent, classic of cholangiocarcinoma. The next scope that I wanted to introduce, new scope, is spiral enteroscope. I think this is already being used. We have a large experience with this spiral enteroscope in our unit. Normally, the challenge is to see the whole small intestine. We had the single balloon endoscope, the double balloon endoscope. In 2/3 of the cases, we would reach the target, but in 1/3 we cannot with these scopes. But the new spiral scopes, which is the motor-driven scopes, we can actually reach this easily, as you can see here. This is the scope that we have, and with this scope, which actually has got a motor spirus there, we can actually reach the tip of the. Actually, very, very often we go into the ileocecal valve and reach also the cecum. You can see the scope here in the small intestine. As I said, very often we can reach the cecum in these cases. And with this scope, now I'll show you an example of a very difficult case where this was a retained capsule in a patient with the Crohn's disease. And you can see this retained capsule. We could, normally we tried with a regular single balloon endoscope. There are several trials outside, it couldn't be done. He came to us, and using the spiral enteroscope, you see how easily it goes to the depth. We find this lesion, which was actually a stricture there in that area. Using a small, you can see very nicely the capsule there. We dilate the stricture, and dilating the stricture, we go up to the capsule. You can see we dilate the stricture with this. You can do all sorts of therapeutic procedures, and the capsule is lying just beyond the stricture here, and you can retrieve the capsule. So this is, I think, the new small intestine enteroscope that's going to take over from what we are doing normally. Now, the third major area that we are going to advance in terms of endoscopy is single-use endoscope. And this is a single-use endoscope that's going to come because of infections, and COVID seems to enhance this. Right now, we have this Invendo colonoscope. Single-use, it costs about €300. So those who can afford it, of course, can use it. But more important is single-use has become in terms of duodenoscope. Because of duodenoscopic infections, there's been a need for this, and we now have EXALT, which is single-use duodenoscope from Boston Scientific. You can see this can be used it's taken out from the packet, and this is one of the first world congresses we're doing with this scope. And you can see this is in Orlando at Rob House and Shyam Vardaraju's unit, and I'm doing this endoscope. You can see the clarity is as good as the regular scope, and after the procedure is over, we just throw the endoscope in the dustbin. So that's the problem with this scope, of course, is the cost factor. It costs about $2,500. So there's going to be a small indication for this. This is for patients who can not only afford it, but very sick patients in ICU, where you want to go in ICU and do this. If the price of the scope comes down, then of course more use will be there. Right now, we are using it in a very limited way. The fourth endoscopic innovation is going to be the endocytoscope, the endobrain. This is, you can see Professor Kudo here in one of our workshops demonstrating this. This endobrain will not only tell us the polyp, but with an 80% chance is a neoplastic polyp. Again, we're starting to get experience with this scope, and you can see in one of our conferences recently, we're looking at a polyp, which we're not sure whether this is the adenomatous polyp, hyperplastic polyp, and we got the answer here. 94% is a neoplastic polyp. So these are all the advantages that are occurring with this endobrain we call. So from the new scope, so I told you about the 4 new scopes, which are going to change the way we practice endoscopes, and how they're already available now commercially. Now let's go to the new accessories. There are several new accessories that are come, and one of the accessories which is just getting to be available is to treat type 2 diabetes. This concept of this came based on the fact that you can actually take these rats which are spontaneously diabetic, escape off the duodenal mucosa, and the diabetes disappears. We can see here very clearly. Swine experiments showed that if you can actually lift the submucosa up and expose the duodenal mucosa to thermal heat and burn the mucosa, then of course you can do the same thing. So we now have the so-called DMR, the fractile Revita procedure. Using a balloon, we can do this, put a balloon and then burn the mucosa completely. And this is now over 300 cases have been done all over the world. A randomized control study is on the way, and this has shown the efficacy of this procedure. And you can see after burning the mucosa, in about 3 months' time, everything comes back to normal. This is the actual procedure. I had an opportunity to use this. It's not a very difficult procedure. It's quite simple. The balloon is there, which is passed on a guide wire, and then you follow it endoscopically, blow the balloon up so that it touches the mucosa and confirm the position fluoroscopically. And then using hot water at 80 degrees, we burn the mucosa like this. It becomes blue. And then what happens is this hyperplastic mucosal endocrine cells change completely, coming back to normality, and insulin resistance comes down. So there are several studies, all these have shown that there is a decrease in A1C, and not only that, insulin resistance comes down, there is a marked improvement in also the liver enzymes. In fact, this was a study from Netherlands which showed that in more than half the patients could be taken off insulin completely using this, and metabolic control is very good. This is probably one of the only procedure now available in the world where you can treat NASH. I know Shivaram will be interested in that. This is his main area. It has been shown conclusively that patients with NASH improve dramatically, and paired biopsies before and after the procedures have shown that there is not only a decrease in fat but also a decrease in fibrosis in this patient. So very exciting for us in the future. The other device, again, which is just starting to come, is called the full sense device. It's a bariatric device, just like an esophageal stent, which can be put in the esophagus, held by thread, blown up in the fundus and pulled back. So it changes the baroreceptors here. Huge hormonal changes occur. Appetite comes down, and the patients lose weight, and also diabetes also, because of some hormonal changes and weight loss, diabetes also comes down. Again, this can be done with a pediatric endoscope together with a regular over tube, and you can see this is how we do it. We put this inside, and with the pediatric scope, you can observing how this stent, see how the stent fits in. We just pull it up a little so it fits into the fundus of the stomach, and causes hormonal changes and produces effects. And again, we have a small series of cases. We have shown quite a good resolution in diabetes and also in obesity. Now, the other area, again, which is just coming in, just commercially available, is the biodegradable stents. So normally when you put a plastic stent, you have to remove them. In very sick patients, you put a completely, metal self-expanding metal stents, completely covered stents, sometimes if it's not very sure whether malignancy or not. But all this is going to change with the availability of these biliary biodegradable stents. These biodegradable stents are available just like the standard stents, and special pancreatic stents are also available. So you can see here, there are potentially many indications for using this biodegradable stent. So you put the stent in, you don't have to go and take it out. Benign biliary strictures, post-cholecystectomy leak, neoadjuvant therapy patients are all indications. In pancreatic, for benign pancreatic ductal stricture, more importantly, we have found it to be extremely useful as a prophylactic pancreatic stent. You do an ERCP, you do a prophylactic pancreatic stent, you don't have to go and take it out. It dissolves by itself, and that's where the use is. And this is a publication of ours, a series of biodegradable stents that we used. So this was actually a Y stent also in a patient. You can see that this stent looks like a regular stent, is not so radio opaque. After you put it inside, we have to use a balloon with contrast to dilate the stent, because the stent doesn't spontaneously open up like a self-expanding stent. It requires force to open it up. And you can see this, we are using this balloon with contrast to open up the stent. The stricture is slowly opening up. And once the stent opens up completely, we deflate the balloon and remove the balloon. The stent stays in place. Even Y stents can be put for two strictures. So if you have a benign stricture, it's very complex, left and right ducts are involved, endoscopically we couldn't treat it. But using this technique now, we can also treat these very complex strictures, and there's no need to go inside and remove the stents because they dissolve after 3 to 6 months. This is like indication for pancreatic stenting. This patient, we did an ERCP. We didn't want post-ERCP pancreatitis because of a high-risk case, and then we're putting in this pancreatic stent which dissolves spontaneously. We don't have to go and remove it. So this is one area. The second area is regarding bleeds. We all know that therapeutic endoscopy is associated with bleeds. But if you can decrease the incidence of the bleeds or control them when you have these bleeds, then of course you become more aggressive as a therapeutic endoscopy. Curastat is a inert peptide gel which, when coming into contact with the physiological fluids, becomes a sheath, and this prevents blood from escaping, and clotting factors concentrate to produce a stable clot. This is how this is used. Curastat is again available commercially. You can see that we can lay, after doing a large ESD, we put it on surface, it stays for a few days, and post ESD bleeds are prevented. Also, if there's an active bleed, we can actually inject this onto the bleed. It forms a surface. It is not effective against spurters, but for slow ooze, it's very effective. And we have found that, so you can see here, there's a small ooze there. What we do is we put Purastat on that. When you put Purastat, it forms a layer and stops the bleed temporarily. And you can actually see through it how the bleed is stopping. Once the active bleed stops, healing occurs. But if there's a spurter, of course, this is not effective. So this is something which has been shown to be very effective to decrease the severity of the bleed and also decrease the indication for thermal treatment of these lesions. Because when you do an ESD as a bleed and blindly you coagulate, there's a chance of post-surgical perforation very high because you're doing deep coagulation. You can avoid that by doing this, and then amount of thermal injury is very less. Another device which again we have, in fact, Dr. Zahir and Dr. Mohan in our unit have pioneered using it for the first time is the speedboat. Speedboat is a device which contains a very special type of knife, a flat knife, which tip is a microwave. On the sides you have RFA energy. So microwave RFA energy is sort of confined to this knife, and there's also an injection portal there. So this can be used at the same time, same setting. We can use it to dissect the tissue. We can actually stop bleeds and so on. And this is a series that we reported using the speedboat. So instead of using a variety of knives, different types of coagulation devices, this single device can be used. And also, we also have a detachable loop now. It's called the Loop 9. If you do a large opening or a perforation and you want to close it, there were difficulties earlier. But using this Loop 9, it's a detachable loop. You actually put it in the stomach. It gets detached in the stomach. And then around this loop, you can put your clips. And then afterwards, you can go in, catch hold of the loop and tighten the loop. So the detachable loop, I think, is another innovation, again, available commercially. So anybody who is doing therapeutic endoscopy with large resections should take this detachable. You have detachable loop in your department, but because very large openings can be closed using this technique. And of course, we have newer techniques, endolifter. The endolifter is come from Olympus, where you have at the tip there, this is Yahagi's invention. You can actually have another channel where you can put in a grasping device. And you can see when you're doing an ESD, the problem is you can't lift this tissue normally, but using this endolifter, you can lift this with the forceps, and then you can continue your ESD. So this is a device which is very cheap. It's available now. You can start using it, especially if you are doing a lot of ESDs. This is a useful device like a surgeon, you can lift up the flap and then keep cutting, as you can see. Other companies are also making it. This is from the Ovesco company. They have a device where you can put in multiple channels. So instead of in your endoscope itself, you can have 2 channels and double channel. With this additional channels, you can have up to 4 channels. So it's like a surgeon working with 4 hands. So this is, again, something that we can use in regular practice. Magnetic anchor-guided clips are also very useful now. And this is, I'll show you how we use this. So when we do an ESD like this and you want to lift up the flap, it may not be so easy to do that. Sometimes we take help of gravity. If we don't have that, we have these magnetic attached clips which are available now, with which you can use the inner magnet and outside magnet on the abdominal wall and lift it up. So you can see the magnet actually lifts it up, and then you can dissect very nicely below. So these magnetic anchor guided clips are very useful when you're doing so difficult ESDs. And of course, we have now devices for full thickness resection. Again, some of this work is pioneered by Dr. Zahir in our unit, where you can use this full thickness resection device instead of cutting completely and then trying to suture. The device automatically gives you a full thickness cut, and the special Ovesco clip that is there goes in and clips the lower end so that the perforation is also closed simultaneously. So this is the FTRD device, endoscopic full thickness resection device, which is now available. And the major indication is in patients who have a T1 lesion, but it can't be resected endoscopically, or those who have a recurrence of the lesion where it is very fibrotic, or if you want a full thickness resection to see the histology, this is extremely useful. And now even full thickness resection for upper GI endoscope has come. Other device we are finding very useful, we are using it a lot now, is a stent fix device. When you put in a stent, especially the stricture is not very tight, it may be difficult to fix this stent. So now we have this stent fix device, which is again a full thickness clip, which is available from Ovesco. After putting the stent, you use this device to clip the upper part of the stent to completely fix the stent to that place. So this may be useful. So you can see the lot of techniques and technologies that are coming in. There are a large number, but because of lack of time, I wanted to confine to 20-25 minutes. I've shown you some of the very practical new technologies that we're using. Of course, it's very important that when you're using these new technologies to get familiar with the techniques, and only then you can adapt them properly in a proper way. But once you master this and once you start using this, you can see that we have a dramatic advantage, a tremendous advantage in therapeutic endoscopy. We can be more aggressive, we can do better resections, we can close large openings. All of this can be done very easily now using this new technology. So I think endoscopy as a whole has gone to a new level with these technologies, and we, I think as endoscopists, can be very aggressive competing with surgery in many of these cases. Again, thank you very much for your attention, Shivram and Ramesh.
Thank you, Nagi. As usual, you have taken us down so many new tricks. The endoscope has literally become Goddess Durga with all the various shastras in her hand. That's what you have done. Thank you. Ramesh, you want to speak something, Ramesh?
Yeah. What is the cost of Purostat, sir?
So the Purostat is costing, it's available in euros. So each vial will cost about 200 euros.
200. Is it available, sir, commercially?
Yes, commercially available.
Okay, sir. Thank you, sir, for excellent talk as usual.
Good afternoon. Thank you, Manoj and Avinash, for organizing such an excellent conference, and we were all able to enjoy all the sessions and the live performances from the comforts of our homes and offices. I am just going to say a few things about sessions 1 and 2. Session 1, of course, was the transmission by Dr. Amit Medyo. All the procedures were demonstrated so neatly and with such finesse and explained very well. What I like about Dr. Medyo's procedures is the field is so clean. You know exactly what is happening, every layer. You really have to say something about the finesse and the skill of Dr. Medyo. In session 2, I'm guilty of not being able to follow all the sessions. There were so many halls, all of them happening at the same time. But a couple of things that stood out to me, 2 or 3 things that stood out to me was, one is that artificial intelligence is going to be coming to endoscopy in a big way. So, especially in diagnostic endoscopy, AI is going to come in a big way, and the younger generation has to accept that and actually make use of it, leverage that technology, be comfortable in using machines and software to augment your skills. It's not a fight between humans and machines. They're going to become superhumans by using the technology that's available. So that is really something that is going to come in the future. But at the same time, we don't have to lose hope that we are losing our importance, because we are taking over areas which are handled by interventional radiology and surgery, which was clear by all the sessions on biliary interventions, EUS-guided pancreatic access, GB drainage, liver biopsy, all the other sessions that were told. I think this technology and the technique is maturing, and people are discussing with each other, and everybody has tips and tricks to make these procedures safe. The accessories are developing along with our understanding of safe principles of doing these procedures. There was a lecture about COVID and how training and treatment has affected us in this pandemic. Hopefully that will be history, and next year we won't have another session like that, and we're all getting our vaccine shots. Thank you again. I'll hand over to Ebi, my colleague. He'll wrap up and give his comments about the other sessions.
Thank you very much. At the outset, let me also congratulate the SGI for organizing this midterm conference, even during these challenging times. With the resources available in the form of technology and great faculty, we were able to witness an excellent hybrid conference. Coming after what AJ just spoke, from session 3, we saw a live streaming from SL Rahija, Hospital Mumbai, by Dr. Medwiz, showed us cases, a case of EUS guided liver biopsy, and also EUS evaluation of a bile duct and the lesion within was found to be a stone, quite opposite to what the radiological imaging had found. We also saw an attempt at transgastric biliary access. Even in the hands of an expert, we saw how challenging it was, and also the need for patience to be a good endoscopist. In session 4, there were multiple sessions across various halls occurring simultaneously. And again, topics such as capsule endoscopy, IBD, vascular endotherapy, bariatric endoscopy, as well as research and publishing in endoscopy were covered. During these sessions, important topics were covered by excellent speakers in the field, both from the national and international fora. We had excellent review of key concepts and techniques. Various contemporary and practical issues were covered. The scope of various modalities and their future were considered. In session 5, we saw live streaming from Medanta Hospital, Delhi. It was led by Dr. Rajesh Puri, who showed us how choledocoscopy was done using the Spyglass DS2 choledocoscope, and also how laser lithotripsy was used to take out a stone. We just heard a wonderful lecture by the chairman, Dr. Nageshwar Reddy, on endoscopy in 2021 in terms of tools that are available. Overall, the conference was educative, well-planned, and nicely conducted. Once again, congratulations to the organizers, and a big thank you to everyone who shared their experience and insight with us on day 3. I would like to conclude with a special word of appreciation for Dr. Avinash and Dr. Manoj Sahu. They are our boys, and on behalf of our department at the Christian Medical College Vellore, we would like to applaud them for the excellent work in connection with this conference. Thank you very much.
I think, Manoj, I'd like to congratulate the team there. This has been, as I said in the beginning, not an easy conference to organize, but I think you pulled off a miracle, not only in terms of the outstanding faculty could get together, but also you got together so many technologies because of hybrid conference. You had the main hall there. I was very impressed when I was there at the inauguration ceremony with the main hall being filled with people. And then, of course, you have these 3-day sessions. And you also, I think this is one of the few times I know of where 5 centers from different parts of the country have actually demonstrated live to a conference. So I think this is another big achievement in your hat. You've been able to do all this, and requires tremendous amount of coordination. Your team has done a fantastic job. And I was commenting to somebody the other day when I was coming back, but from Bhubaneswar, that probably Manoj is one of the best organizers in our gastroenterology society now. Yeah, I think you have fantastic capacity to organize. So congratulations again for this very, very nice conference. Thank you.
Thank you very much, Honorable Chairman, Sir, Dr. A.J. Jasif, Dr. A.B. Saiful. I mean, I'm very close to their hearts. So thank you, everybody. So now we are moving to the last session, their valedictory. So then we'll tell thank you to everybody. So thank you very much. So we are moving to the last session now.